going to talk a little bit about spinal trauma today, one of our favorite things, including discussion of what we need to do with the hospital, with the trauma system. Obviously, spinal cord injury, spinal injury is a real common problem for us. We generally do quite well with, but we still have some sort of a learning curve, as we're noticing from our case reviews. Spine is basically 33 bones. Structure, it's the major portion of the axial skeleton and protective container for the spinal cord. Your vertebral body is your major weight-bearing component. And the vertebral body is anterior to the cord and to the rest of the vertebral components. The cord structures are posterior, dorsal. So the vertebra consists of the spinal canal, the pedicles, lamina, transverse processes, spinous processes, intervertebral discs, and the vertebral ligaments, both the anterior and posterior longitudinal ligaments. Now, I'm sure you can reproduce that list right now, but we'll go on. So this is what we have. So you have your spinal foramina. You have spinous processes, which are biggest in the cervical spine and the first thoracic spine. You have transverse processes. Then the vertebral body, which of course is small when you get up into the cervical spine. This is the atlas, which is the top, number C1, and it really doesn't have much of a vertebral body at all. So as you go down, the vertebral bodies get much larger as they become much more weight-bearing. They have articulating facets, which we can see better in another picture. Cervical spine has 7 vertebrae. I have an old copy of a. Now everybody knows there are 8 cervical nerves. So I have somewhere in my collection about a 1890 chiropractic text that has the 8th cervical vertebra perfectly outlined. Of course, it's a copy of the 7th cervical vertebra. That's a little bit of a joke there. So 7 vertebra. It's the sole support of the head, and the head weighs between 16 and 22 pounds. The atlas supports the head. It is affixed to the occiput, and it permits nodding. Yes, no. C2 is the axis that has the odontoid process, otherwise known as the DONS, D-E-N-S, and it projects upward, provides a pivot point for rotation. Obviously, there's some ligaments attached to those things so that it all doesn't fall apart. Those ligaments are what get distracted, torn during severe cervical injury, hangings, the other likely thing. The odontoid process is also known as the hangman's bone, because that allegedly is what, if you do it right, what slashes forward through your spinal cord and kills you as you're being hanged. Otherwise, you just choke to death. C7 is the most prominent spinous process. Generally speaking, it's almost the same size as T1, and it's called the vertebral prominence, and that's the thing you can feel in the back of your neck, the biggest bump that sticks out there. The only important thing about that is that we use that X-ray wise to measure and to count cervical vertebra. Okay, so this is the atlas. It has, of course, a very large space for the spinal cord. It has an articular facet. Now, facet is articulation. Now, ordinarily, as we get down in the vertebra, you'll see there's a facet off. There's a facet on C2 that articulates with the one above it, which is the atlas. So facet joints are articulating joints between vertebra. And now in the lower cervical vertebra, they're sort of like a joint that goes back and forth mostly. There's slight rotation in it, but mostly it's just sliding back and forth. And when it just like a knuckle, when you pop your knuckle, you get a snapping sound. That's the release of, actually that's the release in the joint of gases that are saturated in the fluid in the joint, and that's the gas popping out of solution that you hear. Now, when the chiropractor snaps your neck, it's the facets that are sliding and popping, not the vertebral bodies itself. It's very difficult to distract a vertebral body. Matter of fact, to distract the cervical spine, we do that occasionally when people have what's called subluxation. They slide the facets over each other, so the vertebra is almost uncorked. It's almost uncocked. So we can get that back in place by putting traction on the person, putting them in anesthesia, and putting traction to their cervical spine. But it takes about 150 pounds of distraction force to move it 1/4 of a millimeter. In other words, a lot of force. Hopefully the chiropractor isn't moving your vertebral bodies that much.
Yeah. You hear that, like...
He doesn't like this.
I know.
So what'd you turn off? That little one was on? Okay, the squirrels are gone. Well, mostly. Any rate, so back to the atlas. We have it has a huge articular facet for the skull. So that's articulating right there to the skull, and then below that, underneath it, it's articulating to the atlas. And this allows you to do forward and some rotational stuff, which is held by the dons, the odontoid process with a big ligament here. There's an articulating facet that articulates right in here with the atlas. Now, you notice these kind of big holes here on the lateral processes, the transverse processes. These are the transverse foramina, and there's another one here. And as you go down the cervical spine down to about C4, you have another smaller one. But this is the vertebral artery comes up, snaking its way up through these little foramina, all the way up to here, and then it dives into the opening into the skull through the foramen magnum up into, and it cuts through a bunch of fascia and ligamentous layers. So on the outside of this, you see there's a longitudinal ligament here. There's another longitudinal ligament in the front. There's a huge conglomeration of ligaments in the back. This is what allows us to hold our neck up, along with the muscle. Now remember, your muscular ability to hold your neck up occurs at about 3 months, 4 months. It takes a lot of muscle control to hold your head up. That's why babies' heads are flopping around. and babies' heads really flop around excessively, only held on by the ligaments at the young age. Now you can see the vertebral artery going up through the foramina here, and then it dives right here. It wiggles in and dives in. Now this is an interesting thing, because as you get older, we get, now you notice there's a kind of a bend here, and this dives through, goes into the foramen magnum. The vertebral artery becomes the basilar artery. So that's the posterior artery that feeds the brain, feeds the cerebellum, feeds the reticular activating substance, feeds the medulla, and ultimately articulates with, communicates with the circle of Willis, with the anterior circulation. Now, as we get older, these ligaments get a little stiff. You get a little arthritis in here. You get a little calcifications in here. And a number of old people, when they turn their head and look up, will pinch the vertebral artery, and that's enough to cause them to become extremely dizzy or to pass out. So it's kind of a bad design there. There's no real protective way that things get into the brain from that point. Thoracic spine, 12 vertebrae. First rib articulates with T1 and then attaches to the transverse process in the vertebral body. The next 9 ribs attach to the inferior and superior portion of the adjacent vertebral bodies. They have rib articulating facets on each rib. So only for the T1 is sort of floating, and then, or the first cervical rib, and then the 11th and 12th rib is also sort of floating. Now, this attachment and this thing of connecting to the ribs and connecting to the spine gives rigidity to the spine, helps protect the chest, the thoracic cavity to some extent, but it also puts you at risk as you get older. For it's easier to fracture ribs. It's easier to have some back injury. They're larger. They're stronger than the cervical spine. Big muscles, and it also helps support the thoracic cage during respirations. And the intercostal muscles assist respiration when you really need when you have need for extra oxygen. So big vertebral body now, smaller spinal canal, cord canal. These are your articulating facet to the vertebra above. So here's this one showing here, and you can see that there'll be its counterpart underneath it. So these are articulating one to the other, allows you to flex forward and a little bit of extension. So this is that now, and this is the costal facet, the rib facet. This is the 12th thoracic vertebra, and it has a single rib facet. These other ones, this is the, will have a superior costal facet and a transverse costal facet. So that's essentially 2 through 9. A rib will attach here and here in both places. Now, these facets can be sublux, can be displaced in injury, and it causes quite a bit of pain and discomfort. And this is actually, although a lot of orthopedists don't believe it, this is actually a reasonable thing to see a chiropractor do to realign they're actually quite good at that. Osteopaths as well. Oh, going back one, notice that the transverse processes are pretty stout because they have to help to control the vertebra. I mean the ribs. Lumbar spine, 5 vertebrae. They bear the forces of bending and lifting above the pelvis. They also have a lot of axial load just because you've got the entire body above it. And then when you're lifting something, lift with your back, not with your legs, right? You get considerable axial loading on it. Now they're very thick. The intervertebral discs are very thick. As you can see here, they theoretically get thicker as they go down. You've got large spinous processes, really bulky kind of things that are supporting muscles and ligaments. The articular processes and facets are really heavy, block-like. And the spinal canal is fairly narrow in here because the spinal cord actually ends about here. Becomes the cauda equina. The spinal cord separates into this horse's tail thing, all individual filaments, which is what allows Dr. Bell and I to do a spinal tap where you put the needle into the spinal canal there, but you don't run into the nerve. If they squeal at you and all of a sudden become, you know, paraplegic, you've done it wrong. You've gone too high. So we measure, we feel these things down here, and you know, you say, well, okay, this is the first, this is the second, and we're going to go into the second or third. So just trying to get into the through the dura and get some spinal fluid. Sacral spine, ordinarily 5 fused vertebrae. It's the posterior plate of the pelvis, helps protect what's in there, attaches the pelvis and lower extremities to the skeleton. The coccyx, what's a residual element of a tail, 3 to 5 fused vertebrae. So these vertebrae are fused. Now, occasionally we will find unfused, some evidence of poorly fused or unfused cervical or sacral vertebra, but it's uncommon. Now, these are fused, they're a little looser. This gets broken often in a bad fall and can be quite painful because there's not much you can do about it. Here you have your foramina, posterior sacral foramina, so ways for nerves and things to get through. You have the superior articulating facet, and then the rest, this goes to L5, and the rest goes here. Often you get you get what's sort of an L1 or an L6. The first sacral is unfused or incompletely fused, and we can see it on X-ray. It looks more, and so theoretically the person has a little bit longer spine. It's really not. It used to be thought to be a big problem that would make their spine more mobile, more prone to injury. I don't think that's ever borne out any scientific proof, but it's always good to tell a patient that's the reason, I guess. Now, a couple things to consider for pediatrics before we go on is that infants have the ratio of head to body is very big. So the head size compared to the rest of the body is huge. So it's heavy. And they don't have neck musculature that's developed yet. They don't have the nervous control of it, and they haven't developed the ability to protect their spine with their neck muscles. Their discs are full of they have a high water content, which makes them more likely to have shear forces. Their facets, instead of being somewhat vertical, are horizontal and shallow, so it's more prone to shear again. Their naturally, their cervical vertebrae are anteriorly wedged forward, because babies are curled like this for a long time. And they're almost always anterior. So when you take an X-ray, when we take an X-ray of an infant, it often looks like they've got some anterior compression of the vertebra. They don't. But with this anterior tipping, it's more prone then to injury flopping forward. That's why we put babies in backward facing car seats, because you don't want them going forward in a car seat in a sudden stop. The odds are that they're going to hit head on rather than being hit from behind. They don't have any uncinate process. Now, it didn't show well, but in the normal cervical vertebra, from vertebra 3 through 7, there are laterally a couple of ridges that rise up on the superior portion. They're called the uncinate process, and they help to stabilize the vertebra in the adult. Babies haven't developed that yet. So they're a little bit more, so they're more prone, just like all these other things, weak muscles, high water content of the disc, narrow or shallow horizontal facets, and then they're prone to lateral rotational and shear forces. And then their vertebral growth plate is quite brittle too, so if they do sustain an injury, they can have prolonged consequences. All right, back to the spinal anatomy. The layers of meninges are the dura mater, the arachnoid, and the pia mater. Cover the entire spinal cord, peripheral nerve roots that exit from the spinal cord, and the CSF fills the subarachnoid space. So the cerebrospinal fluid has nutrients, removes waste products, and is there as a hydraulic shock absorber. Your cord, when you look at the cord, the next picture, there'll be an anterior medial fissure, which is a big crease along the ventral. Ventral is the anterior part. It divides the cord into the left and right side. There's a posterior medial fissure, which is more shallow. It's on the dorsal surface, the back side, and it also helps to divide it. The central area of the spinal cord is dominated by nerve cell bodies, so it's gray matter, same as the brain. White matter is surrounding the gray matter, and it's comprised of the axons, your nerves themselves. So, dorsal medial sulcus, ventral, and this is gray matter, this is a C3, and then white matter surrounding it. And this recapitulates itself all the way down the spinal cord with varying sizes of the central gray matter. You notice this is at T2, a lot of action happening up there in gray matter, and then S2. Now, the fact that this is central gray, that this is brain matter essentially, is sort of the confounding problem of why we can't heal after cord injury, because we haven't figured out ways yet to heal brain. You kill brain gray matter and it's killed. The axons, the more peripheral they get, then you can heal. So a peripheral nerve, after the axon leaves, let's say it leaves T2, wanders out toward the upper thorax, it's got sensory fibers, it's got motor fibers in it, and if it's injured, it can, under the right circumstances, grow back. It actually grows out from that. But if you actually injure it at the level of the cord, it's pretty well not able to be reproduced either. Axons transmit signal upward to the brain or down to the body. So the ascending tracts transmit signals to the brain. They're essentially, think of them as the sensory tracts. And sensation is pain, light touch, movement, the proprioception, the sense of where, you don't think about it, but you know when I'm standing here, I know where my feet are. My brain knows where my feet are by the feedback it's getting from the feet. And it knows that I'm standing on one or the other, and you don't have to think about it. It's kind of out of your control. But we test for proprioception, and then there's heat and cold sensation. Descending tracts transmit signals from the brain to the body. Those are the motor tracts. Voluntary and fine muscle movement, both. Now, the blue in this is ascending pathway, and of course it reproduces on the blue would have been on this side too. It just makes it really too confusing. So remember, the ascending tracts are the sensory tracts. So they're primarily on the posterior, the ventral side. But you have some sensory tracts on the far lateral side. These are the descending or motor pathways. And these are fibers that go in both directions. Now, a lot of the reflexes occur at this level, where a fiber can come, a sensory fiber will come up and send upward information to the brain, but also will involve a reflex, and the reflexes occur at the gray matter. There are 31 pairs of nerves, anterior and posterior nerve roots, sensory and motor functions. They travel through the intervertebral, they exit the spinal cord and go through the intervertebral foramina. The first pair exits between the skull and C1. And that's an interesting, from a clinical standpoint, that's interesting because a lot of people develop what's called cervical spinal neuralgia, which is severe headache that's caused by probably an inflammation at this level. And these have been sort of problematic patients because they're high drug seeking because it's really very painful, and it goes away with narcotic medications. But they also, unfortunately, a few of us have injected these trigger points with steroids and lidocaine, which means we've just adopted a new child because they always want to get that done because it gives total relief for X amount of time. But it's not a permanent thing. The remainder, after you get through the first cervical nerve, the remainder of the pairs exit below the vertebra. Each pair has 2 dorsal and 2 ventral roots. The ventral roots have the motor impulses from the cord to the body. The dorsal roots have the sensory impulses from the body to the cord. Now, C1 and coccyx 1 don't have dorsal roots. It all happens through the ventral root. Now, there are plexuses. Plexuses are nerve roots that converge in a cluster of nerves. The cervical plexus has 5 cervical nerve roots, C1 through C5. They become the phrenic nerve. The peripheral nerve roots C3 through C5. And they're responsible, so it has the cervical plexus makes the phrenic nerve, and it makes cervical nerve C3, 4, and 5. Now, it is responsible for diaphragm control. So if you give it a high cervical injury and you knock out your phrenic nerve, you are ultimately dead because you don't have any diaphragm control. Brachial plexus is C5 through T1, so it's got a little bit of C5 that would have gone to the cervical plexus, but the brachial plexus starts at C5 and goes through T1, and that's your control of your upper extremity. The lumbar and sacral plexus innervates the lower extremity. So that's all L1 through S1, S2. So C1 through C5, phrenic nerve, diaphragm. If you injure it, respiratory paralysis. C5 through C8 and T1 is the axillary nerve. So axillary in the axilla. And if you injure it in the axilla, you will have varying, depending on the severity of the injury, you have, does anybody remember the guy who got a moving chainsaw in his armpit about 4 or 5 years ago, died en route to the ED, but was resuscitated in the ambulance and went off to, he had a, axillary artery was chewed up by along with the axillary plexus. And so he ended up with, and he survived, did quite well. He ended up with a repair of his brachial plexus, and he's got pretty much normal return of motor function and sensory function of his hand, of his arm and hand. It took a long time because it's a peripheral nerve and it takes a long time to grow. Took very good surgical care to fix him in the first place, but then to make it happen. But if you get now the brachial plexus then spits off the axillary nerve, and then that breaks up into the radial, the median, the musculocutaneous, and the ulnar nerves. The radial nerve controls your triceps and forearm. So if you injure your radial nerve, you end up with what's called a wrist drop. You can't raise your wrist. Median nerve controls the flexor muscles of the forearm and the arm, so you just have decreased flexion and function of the arm. Musculocutaneous is flexor, once again, of the arm, so the kind of things that flex. Ulnar nerve controls the wrist and the hand, and so the hand becomes a claw-like thing if it's totally cut, or just decreased usage. The most sensitive thing to test is ability to spread your fingers. What makes us different than other, is we have the ability to prehensile, to grab things and pick it up. But here's the big thing: it's being able to oppose your little finger and your thumb. That's a simple test. Then being able to abduct the fingers is really T1. Abduct the fingers. You have to be able to both abduct and adduct. So abduct your fingers to make them work correctly. Lumbar plexus, you end up with the femoral and obturator arteries, and if you get the femoral, which is the high lumbar, that affects your lower abdomen, your gluteal muscles, and your thighs, and it's the inability to extend the leg or flex the hip. Obturator muscles, obturator nerve is the abductor muscles of the thigh. The one abduction is to bring together. Sacral is your sciatic, decreased usage, weakness of an ankle drop, foot drop, weakness of the lower extremity below the hip. Mm-hmm. Right. I would think that a sudden blow to the cervical plexus in the form of a karate move or something would as well cause respiratory difficulty. Okay, myotomes refer to the concept of certain that the body will be innervated by spinal nerve roots, and there will be specific muscle groups involved that will help you to determine more easily than the last slide where the injury may be. So the key myotomes for you guys to remember is arm extension. If they can't extend their arm, that's at the level of C5. And then everything else below C5 will probably be paralyzed too. Elbow extension, so arm extension, elbow extension is C7. Small finger abduction, T1, so you jump down a long ways. Knee extension is L3. Ankle flexion, flexion is to go down. Ankle flexion is S1. Okay, now, I briefly mentioned reflex pathways. Function of reflex pathways is to speed your responsiveness to a stress, to reduce seriousness of injury, and for body stabilization. And they occur in special neurons called interneurons, which are in the spinal cord itself, in that gray matter stuff. For example, if you touch a stove, you get pain from that. That travels up to the brain. It would take a little time to process that, seconds, microseconds, whatever. But if your hand was still resting on that hot stove, that could be bad. So at the same time it's going upstream, it goes to the interneuron within the spinal cord and causes a reflex that makes you, without saying ouch, pull your hand away. It's the reflex. Now the same thing, reflexes occur. Now there are simpler reflexes, patellar reflex, ankle jerk reflex, brachial reflex. Those also occur at that level, and that's at the level of the spinal cord, and that's to speed up the reaction. Now, when those are confused, now those are all damped by the brain. What I mean by that, if I were to tap you on your patella and you'll have the knee kick, knee jerk response, if that weren't damped by control of the central nervous system, the brain, you would continue to have that reflex, because when you kick, it stretches your patellar tendon too. So you'd keep jerk, 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 uncontrolled. And that's what we test for when we have what's called clonus, repetitive reflex jerking, which is a sign of stroke, for example. So if I'm testing ankle reflex, you pull up on the foot like this, and the normal response is is nothing or maybe one little kick. In clonus, they go, because there's no control of the brain on that reflex. Now, your autonomic nervous system is broken into parasympathetic rather, feed and breed, controls rest, regeneration. These arise from peripheral nerve roots from the sacral and cranial nerves. Major functions are to slow heart rate, decrease digestive system activity. They do play a role in sexual stimulation too, but that's probably not our concern at that point. Then there's the sympathetic side. It's the fight or flight. That sympathetic increases metabolic rate. There are branches of nerves from the thoracic and lumbar regions. Major functions are to decrease organ and digestive system activity by vasoconstriction primarily, and primarily by the release of epinephrine and norepinephrine. They also increase systemic vascular resistance, reduce venous blood volume, increase peripheral vascular resistance by releasing epinephrine and norepinephrine. They increase the heart rate by releasing epinephrine and norepinephrine, and increase cardiac output by the same thing. A very busy slide. So you've got your parasympathetic side through these guys. So the glossopharyngeal nerve, 9, and the vagus nerve, number 10. The glossopharyngeal doesn't do a lot, goes to your salivary glands and so the parotid gland primarily. The vagus nerve, that's where all your action is. It starts out, it's cranial nerve 10. It starts out at the top. So you start innervating actually there's a small branch, as I've told you, called Arnold's nerve that is up as high as the lower 1/3 of your tympanic membrane and aural, A-U-R-A-L, canal. Trachea, hypopharynx, pharynx, bronchi, to the heart, to the stomach, to the rest of the gut, all the way down to the bottom. Vagus nerve. Now, you've got sacral, or the pelvic splanchnic nerve, which comes out of the lumbar and sacral, and it innervates the rectum, the bladder, prostate, urethra, etc. Down the sympathetic side, you've got ganglia, cervical ganglia, thoracic ganglia, abdominal ganglia, and then they give out other branches. So from the cervical sympathetic, you get branches that go to the lung, get branches that go to the heart, get branches that go to striated muscle. Then you've got the celiac ganglia, goes to the celiac ganglia, here goes to the stomach, goes to part of the intestine, the superior mesenteric ganglia to the rest of the intestine, the inferior mesenteric ganglia goes to the rest of the intestine, and then you have, what is this thing here? It's called the suprarenal gland. That's the adrenal. Sits on top of the kidney, and that is and that's innervated by the sympathetic system It will produce adrenaline partly on its own, but that's its main stimulation is by the sympathetic nerves. It has to be stimulated to work. You want a break? Huh?
No, let's keep grinding.
Okay. Okay. All right. So now we've got a background of what's going on with the how we get there. What happens to the spine? How do we get spinal injury? Well, depending on your age and all, it's extremes of motion. So hyperextension is very bad. Hyperflexion is not good either. Excessive rotation, lateral bend, twist, axial stress, direct loading. Compression injuries are common between T12 and L2. Distraction, where things are sort of ripped apart. And then a combination of distraction, rotation, and compression flexion is not good. Other mechanisms, you can either have direct, blunt, or penetrating trauma, obviously, and then electrocution is its own special thing because of extreme muscle contraction. You can get spinal injury. With things like severe seizure, I've seen dislocations of shoulders and other injuries. I've never personally seen a spinal injury, but I could imagine it could happen. Of course, your spinal injury, the bad seizure, you seize and fall down, hit your head and neck. So, flexion injury, extreme flexion injury, flexing forward, compression, diving injury, distraction, pull things apart. So remember, I said it took about 150 pounds to distract the cervical spine. Well, if you're a 250 pounder and you're hanging yourself, you've got enough to distract that. Hyperextension injury, whiplash type of injury, flexion, rotation, and then penetrating injuries. So movement, you can injure the vertebral column by moving a vertebra from a normal position to an abnormal position. So you can get subluxation or true dislocation. Well, so we've got this is the axis. This is C2. It doesn't belong like that. This really this whole thing here should have come up and sat right here. That's clearly a fatal injury. The Dons is probably lying somewhere in here, being snapped off. Intervertebral disc can rupture and separate. Common sites of injury, C1 and C2, because the vertebra, remember, there was almost no vertebral body there. It's all lamina and processes. Very delicate. C7, when you go through C7, now, remember, T1 is real stable. It's big. It's got better attachment below. It's got 2 rib attachments on each side, which give it some stability. The one above it only has 1 attachment, so you've got a real flexing, extending area, C7, and you've got a pretty stable T1 that's prone to injury then at that junction. T12, L1, same thing, different flexibility between those two. The injuries occur, cords. Cords can be concussed, just like the cerebrum can be concussed. Temporary and transient disruption of cord function. A cord, no, it will come back. But just like a concussion, you can't guarantee it comes back entirely the way it was. Contusion is a bruise of the cord. There's actual tissue damage, vascular leakage, there's swelling. It's just like a sprained ankle, it's swollen. Compression, fracture, compression secondary to of the cord, secondary to displacement of the vertebra, to herniation of a disc, and then the disc material protrudes into the spinal cord and compresses it. Displacement of when you get burst fractures of the vertebral body, they can shear backward and into the cord structure. And then swelling from adjacent tissue injury. You get torn ligaments, torn muscle, it bleeds and it swells, and you get edema, and it can compress the cord. This is a C4 burst fracture, and see the C4 has been, but this is probably pretty stable because the burst, it did not impel itself back into the cord structure. There may be a fair amount of swelling there, which could do some cord compression. You can lacerate the cord from the bony fragments. Cord can be stretched to the point of tearing. Hemorrhage into the cord tissue, you get swelling, disruption of impulses. You can get hemorrhage of the cord itself associated with a contusion, laceration, or stretching. A vertebral artery can rupture. Hemorrhage, compressing the cord. That wouldn't be too hard to figure out. But that can, certainly do the job through the cord. Cords can be transected. Transection is an injury that partially or completely severs the cord. If you get a complete transection in the cervical spine, they will become quadriplegic. If it's high cervical spine, they'll be quadriplegic and respiratorily compromised. They'll also have incontinence. You've lost bladder control, respiratory paralysis. Below T1, they'll have incontinence and paraplegia. And you can have an incomplete cord transection, which can give you a partial, can give you hemiplegia. So this is atlantoaxial dislocation, sort of like that other one. This is C1, this is C2. They should have been together like that. You can also tell that this person is, if they're alive, or if they were alive at that time, they were intubated because they were not breathing on their own adequately. Okay. Mentioned that you could have an incomplete transection of a cord. So anterior cord syndrome, anterior vascular disruption, could be from an injury, could be from a fall, could be from flexion. So what happens is that you lose the anterior portion of the cord. You lose motor function and sensation of pain and temperature below the injury site. Retain fine touch, positional, and vibration sensation, which are the dorsal columns, below the site of the injury. So it's a mixed pain loss and sensation loss. Central cord, which is a hyperextension injury of the cervical spine usually. Now we had an example of that as a case review on the last time we met. This was an older gentleman, and these are generally found more commonly with older persons with some cervical degenerative disease. He was older, he was in his late 70s or so, and fell down in a rock quarry, hit his head, extended, and complained initially of some paresthesia and then some motor weakness. He said his upper extremities were weak. By the time they got there and checked him out, his motor function appeared to be okay. Transported, and then over a period of an hour or so in the ED, he developed more profound weakness to the point he could not raise his arms, and he had some sensory loss that corresponded with that. He also had some moderate weakness of his lower extremities. The motor weakness affects the upper extremities to a greater extent. So it's a cervical injury, and the reason it's caused by hyperextension, the thought is the cord wrinkles on itself and it squeezes the central portion, and that's where the central portion of the cord is where your motor control is more prominent in the center, as the closer you are to the level of weakness. So the motor sensation to the brachial plexus and upper arm is concentrated in the center of the cord at that point. So it comes out, and then as you go lower on the cord, the outside portions are the ones that of the cord are what's controlling the lower extremity. So you get a squeeze primarily, an injury primarily to those upper motor neurons. You get often a little bladder dysfunction with this too. Now Brown-Séquard syndrome is a special thing, penetrating injury, and it affects one side of the cord only. And what you do is you get same side sensory and motor loss, but opposite side pain and temperature sensation loss, because pain and temperature sensation crosses in the cord about 1 or 2 levels above where the nerve actually exits the cord. So it crosses, I don't know why, nobody knows why that does, but it's just a crossover thing. So you lose pain, at least light touch and warmth sensation, movement sensation on the side of the injury, and the opposite side you've lost pain, pinprick, severe pain, and temperature because it crisscrosses. There's a cord compression at C or T6, T7, T8, and you can see that there's a complete compression and a complete loss. So this is a paraplegic. So, general signs and symptoms of spinal cord injury. Well, extremity paralysis, pain with or without movement, tenderness along the spine, impaired breathing, spinal deformity, priapism, which sort of limits it to no more than half the population, posturing, loss of control from the brain, loss of bowel or bladder control, nerve impairment to extremities, motor and sensory. Spinal shock is a temporary insult to the cord, affects the body below the level of injury. Affected area becomes flaccid, weak, flaccid, not moving, without feeling. Flaccid paralysis, no movement. Frequently lose bowel, bladder control, sometimes priapism. Hypotension secondary to vasodilatation. You've temporarily lost the sympathetic control. Neurogenic shock, also known as spinal vascular shock, occurs when the injury to the spinal cord disrupts the brain's ability to control the body. So you lose sympathetic tone. Dilatation of arteries and veins, expanding the vascular space, get relative hypotension, drop their blood pressure. Reduce cardiac preload because it's all dilated. It's all spaced into the vascular system, and when you reduce the preload, you reduce ultimately strength of contraction through the Starling mechanism, so they don't get as much. They don't get cardiac output. The autonomic system loses the control over the adrenal, so you're unable to control the release of more epinephrine and norepinephrine. So loses all your inotropic and chronotropic effects of the epinephrine, norepinephrine, and it lasts for X amount of time. Neurogenic shock, so think they just took away your sympathetic nervous system. Bradycardia, hypotension, cool, moist, pale skin, particularly above the injury. Warm, because that's still getting some sympathetic stimulation, unless it's a really high cervical. Warm, dry, flush skin below the injury because you have only parasympathetic stimulation and perhaps priapism. Now, a special thing for children. Now, there's a thing that we have had for years and years and years in emergency medicine. It's called SCAWARA, and it means spinal cord injury without radiographic abnormality. It means we had a kid who had a mechanism injury and maybe some symptoms, and we X-ray their neck, and you can't see anything, because X-rays are only as good as we think they are. And these kids often have significant injuries because, as I said, the little kids, their heads are big, their necks are weak, the anatomy is such it predisposes to distractional kind of things and rotational injuries. We almost don't have anything called SCAWARA now since we've got MRIs. Because an MRI is pretty good for looking at ligaments, intervertebral discs, other parts that we couldn't see by ordinary X-rays, and including CAT scans. CAT scans are good for bones and blood, but they're not good for ligaments. They're not good for those subtle kind of neurologic things. The mechanism of injury for the kids are primarily, and this is in order, hyperextension injuries, hyperflexion injuries, distractional injuries, where they twist out of shape and distract their spinal cord, and then spinal cord infarction caused by vascular damage at the time of that injury. In under 8 years old, the primary causes are motor vehicle accidents, particularly in infants who are not in the correct seat belts or seat controls, falls, little kids who decide to go out the window, second story, or child abuse. Over 8, motor vehicle accidents and sports injuries. Sports injuries, and this is where things like football in little kids, soccer in little kids, heading, kids who are in gymnastics. Now, how do you treat a child differently than an adult? Same difference. ABCs, but your neuroeval, I mean the very bottom thing, that last S, suspect injury based on the mechanism. Ask them for paresthesia, paralysis, any pain losses when you're examining. History of transient paresthesias and weaknesses highly correlated with severe injury, because they continue to swell after they've seemed to get better. Sometimes a cervical injury on a child doesn't show up for a few days, or doesn't come to our attention. Spinal immobilization based on your evaluation and your mechanism of injuries, and ABCs. Okay, let's take a break for just a little bit. I wonder if we have enough time. We're moving along here. All right. National Association of EMS Physicians and the American College of Surgeons Committee on Trauma published some at least informed material on the use of a long backboard in provision of spinal precautions. Their committee findings were that the long backboard benefits were essentially unproven. Nobody has done a scientific study of it, because this is really not something that one can do a scientific study on, because you're never going to get an IRB to say, yeah, you can take some people with presumed spinal injury and don't take care of them, and some you should take care of. You know, that's kind of hard to do. But we know that a long backboard can cause pain and decreased tissue perfusion. The use, they thought, was that the use of a long backboard should be judicious, meaning you use it sparingly and carefully. Maybe carefully is the better word, not sparingly. And the benefits should outweigh the risk. Now, they did say, their position statement, that appropriate patients for long backboard immobilization were blunt trauma with altered level of consciousness, spinal pain or tenderness, neurologic complaints, paresthesias, weakness, whatever, anatomic spinal deformity. When you examine them, you feel their spine is not in the right alignment. High energy mechanism of injury with any one of the following. or all of them for that matter. Intoxication, inability to communicate, they're deaf, they don't speak English. Distracting injury. Now that's always been our big bugaboo, distracting it. What constitutes a distracting injury? We'll worry about this. Now, they felt in the position statement that immobilization on a long backboard is not necessary with a GCS of 15 and no spinal tenderness or deformity, no neuro findings or complaints, no distracting injury, and no intoxication with drugs or alcohol. And also, patients with penetrating trauma and no evidence of spinal injury, no weakness, paralysis, etc. of a spinal injury, you should not immobilize those with penetrating injuries to a long backboard, penetrating of the neck primarily, because you lose the ability to manage the injury. And it makes it much more difficult to handle the airway. Spinal precautions, they did recommend spinal precautions with a C-collar and immobilization to the gurney if the patient were ambulatory at the scene, patient required long transport, or where a long backboard was not otherwise indicated. Now, they did say minimizing movement and attention to spinal precautions is still paramount. Now, we've added a little thing in our end of it. Now, we do not have the problems with immobilization of the backboard that most of this stuff comes out of places that where the physician doesn't see the patient promptly when they arrive. Now, that is not particularly a West Coast problem. That's a problem in Baltimore, a problem in New York, a problem in other places, primarily on the East Coast, where they have way too many people, way too much action in the ED. And it's not uncommon for someone who doesn't come in as a code alert to wait for 3 to 4 hours before someone evaluates them in an ED. And if you can imagine laying on a backboard for 3 or 4 hours, if you're an old person or even any normal person, that can be quite uncomfortable and can lead to a lot of problems. In our system, we did add, primarily because the trauma surgeons, who apparently have never read the report, are quite anxious about cervical spine injuries. So our caveat is all patients who meet trauma system activation due to blunt trauma, you might notice this is blunt trauma, will have at the minimum application of a cervical collar. If immobilization to a long backboard is impractical or not indicated, or leads to patient deterioration, put a cervical collar on and immobilize to the gurney in a supine position. Now, we have brought people in a semi-Fowler position because their breathing was compromised in a supine position. Old people with COPD are not too good. So how do we assess our spinal injured patient? Rapid trauma assessment, focused assessment, rapid assessment. If you suspect or have likely spinal column injury, index of suspicion should be higher in patients 65 and older. Some authors are saying 55 and older. I'm still sticking at 65. Multi-system trauma patients, evaluate the neck for deformity, pain, crepitance, warmth, tenderness. Examine bilateral extremities for finger abduction. Remember, that's very sensitive. Grip strength, push, pull grips. Motor and sensory function. Dermatome and myotome evaluation, looking for cervical injury versus thoracic and lumbar injury. Some of you still do Babinski, which is, you know, that in trauma that probably doesn't have as much much application to Babinski. Positive Babinski, upgoing toe when you stroke the bottom. You have to have their shoes off. You have to, you know, stroke the bottom of their foot, shoes and sock, stroke the bottom of the foot, and their toe goes up. It's supposed to go down. That might be really positive in a stroke. You know, you should have pretty good evidence of a stroke. With spinal cord injury, that also would be positive if you've got hemiparesis, paralysis of that extremity. But you already should know that they're paralyzed. So I mean, I think it's kind of overkill. You don't have to be that subtle. And then hold up position. You know, if they get a cervical spine injury, low cervical spine, often the only muscles that they don't have the control of the muscles to pull the arms down. Their arms will go up. Vital signs. Well, it's nice to get body temperature above and below the site of injury, but that's pretty high. We're not asking you to do an oral temperature and a rectal temperature. So pulse, blood pressure, respirations, the usual thing, looking for spinal shock or for neurogenic shock. Ongoing assessment, recheck, 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 recheck. Spinal alignment, patient should be in a neutral inline position unless it's impossible, unless it affects their function. We had that guy who we got a little bit of grief from the trauma surgeons because guy came in on his side with really good padding and all that to control his cervical spine, and they said, well, you didn't have him on a backboard and you didn't have him in a, he was actually on a backboard, sideboard, and you didn't have him in cervical collar. Well, when they flipped him on his back and put a cervical collar on him, he stopped breathing, and they had to intubate him. So the guy had a distractional injury. He had a subluxation and distraction of C5 and 6, and it was locked in position. And when you tried to put him into position, you know, so you have to use your judgment on evaluation of that. If what you're doing makes it more difficult to maintain his ABCs, you have to stop what you're doing. Hips and knees should be slightly flexed if you can. If they've got lower extremity injuries, you can't do that. Place support the head and neck, though. So contraindications to neutral position is movement increases pain, noticeable resistance is met, or increase in neurologic deficits, or gross deformity of the spine, or compromise of their respirations. So less movement is better. Now, if they have neurogenic shock, remember, vasodilatation, hypotension, bradycardia often. Fluid challenge first, isotonic solution, dopamine for blood pressure. You can use atropine for heart rate. I would, if you had a profoundly bradycardic and hypotensive person, I might consider doing an epi drip because it'll drive both your blood pressure and your heart rate. Combative patient, sedatives, prevents any more. Now, really combative patient, you may have to go beyond Versed. You may have to go to your antipsychotics. Haldol, etc. So medications would be Versed, Haldol. Now, as you need to manage the rest of the patient, paralytics and intubation. Remember, as soon as you paralyze somebody, though, and markedly sedate them, they've lost the ability to help to protect their spine. So that's when you need to be careful packaging. Our spinal immobilization algorithm is pretty straightforward. It has not changed despite what everybody thinks it's changed. It really hasn't. This is exactly the thing that we'll give Mark credit for that one. He's the first author on this. We published this 24 years ago? 20 years ago in GEMS. And it's held up. Consider mechanism of injury, and then patient mentation. Is there decreased level of consciousness, alcohol, drug ingestion, loss of consciousness involved? Subjective assessment, cervical, thoracic, or lumbar, spinal pain, any numbness, tingling, burning, weakness. Objective findings, cervical, thoracic, or lumbar deformity or tenderness, other severe injury present, that distractional injury, pain with cervical range of motion. If yes to any of the above, immobilize. If no, may treat and transport without spinal immobilization. If it's a neck injury without neurologic deficit, transport without spinal immobilization, especially that C-collar. Now, if you enter them into the trauma, because, so patients entered into the trauma system because they fit one of the criteria, or because of your suspicion. They're old. Well, if you enter them in the trauma system, at least put a cervical collar on them and immobilize them to the gurney. If you think they have a spinal injury, or if their mechanism, old person falls down. Old person falls down is on anticoagulants. Not just spinal injury, it could be head injury. You need to then immobilize them on a backboard and put a C-collar on them. Now we've got some case reviews which I think are germane to this. And then some that aren't. So, okay. On arrival, patient's husband said, patient was fine when he went to bed last, and then he found her on the kitchen floor this morning. She has some rib pain from fractures that occurred over the weekend from a fall 5 days prior, and evaluated 2 days before. She has not received a 30 milligram morphine dose today. So now we have some interesting things in my mind, like why is she taking 30 milligrams of morphine? Is this because of her injury, her rib injury 5 days ago? Is it because of some ongoing thing? Why is she laying on the floor now? Patient states she fell and her neck and head hurt, and if she lets go of her hair, her head will fall off. So now my suspicion is really high. It's a little bit like the guy who's hitting himself in the chest, saying, if I don't do this, my heart will stop. Fire reports that the patient will strike out to hit them with arms and/or legs. She has a past history of lupus, fibromyalgia, and psych. Meds are bupropion, I don't even know what lamotrigine is, amitriptyline, morphine, and others. Patient lying on the floor, lower half back is supine, upper half right recumbent, gripping the back of her head. She flails about when assessment is made of neck or head. Skin warm, pink, dry. Unable to adequately assess neck or back. Rule out fall. 2 milligram Versed for agitation and comfort to move patient. ABCs, vitals, monitor, IV, cabbage, no change, en route to ER, room 5. So glucose was fine, got some midazolam, blood pressure. Blood pressure was okay, pulse is 80 and regular, GCS 15. So, patient trend. Now, she is 61 years old. She has bipolar disorder, chronic non-malignant pain. Had fractured ribs. This is hospital data. Agitate. So she got Versed. Once again, stating, if I don't hold my hair, my head will fall off. EDMD note says patient refused cervical collar en route. EMS note does not mention refusal of collar or other attempts. You need to put that down. Neurologically intact to exam in the ED. Diagnosis, C1 burst fracture. No apparent impingement. Now, anybody pick up she went to hospital bed 5? Where is hospital bed 5 at Peace Health? Hospital bed 5 would be in the pediatric fast tracky area. Hospital bed 5 is at Salmon Creek. So this is a Trump. What part of this patient cleared my C-spine protocol? None of them. We got an altered patient, number 1. Number 2, we have a distracting injuries. Number 3, she's complaining of cervical pain. The fact she's so wacko that she's not going to allow you to examine her and is not. This is probably a case for Haldol, little Geodon help, and she ends up ultimately being a non-emergent cervical injury, but she has a cervical injury, and she should go to a trauma center. Dispatch code 1 for a patient who fell at the jail. Uh-oh. On arrival, patient is lying on the ground in a cell with Vancouver Fire and jail staff. Now this obviously comes off the AMR report. Staff reports patient jumped headfirst from a sink in his mental health cell. He's on a suicide watch. Staff, per video, believe the patient didn't lose consciousness. They must have sat there and watched the video over and over again. Have you seen the video now? Yes, I'm sure he did. And the video has been viewed since, and he does, in this, he does get up on top of the sink and dives, a beautiful swan dive, right to the ground, arms at his side. Vancouver Fire, yeah, he got a 10. Vancouver Fire applied C-collar, and the jail staff had already applied a bandage by the time AMR got there. Patient's alert and oriented, appears to have mental illness. That was kind of a given, I guess. So, at that time, there was some question of spinal. At that time, there was some question of whether the C collar was applied, or they were simply holding cervical immobilization. I have to admit, the Vancouver fire medic did not consider this a serious injury at the time. Patient had a 2 to 4 inch laceration to his forehead, broken front tooth, blood in his nose, and complains of posterior neck pain. He was given fentanyl in increments. He couldn't establish a pain scale. But remember, he's not perfectly normal either. He had inappropriate conversations during the transport. He said he had killed somebody. He was going to sacrifice himself today, little things like that. An officer accompanied during transport with handcuffs on, supportive care without. So he was entered as a trauma alert, or modified trauma. Vitals were okay. So we go through there. He had no apparent neurologic deficit. There's a period of time, there was a delay in arrival of ambulance of about 15 minutes. And so there's about a 15-minute time period where there's questionable C-spine control. Went to CT, had a comminuted anterior C5 wedge fracture with grade 1 retrolithosis, which means part of it goes backward. However, the MRI, which is the head, showed no spinal cord impingement or changes of the spinal cord itself. There were no hot spots on the MRI. So the posterior elements of the spine were thought to be normal, intact. His neuro exam stayed normal. Neurosurgery said, well, we think we should just manage this non-operatively. You know, this is not a person that I would be really anxious to take to surgery and then deal with as a post-surgical problem. And they felt that he's not a good candidate to put a halo on, because you get this halo pinned in there and he's going to jump off something again, and then he'll really be kinked. So they said, well, you know, keep him in a C collar for 3 months, because he's going to go, you know, to a psychiatric institution for a while. So he's probably at Western States now, and he went back to jail. Great. Yeah. Yeah, this is. Mm-hmm. Yeah, it turns out we have, how many beds do they have there now? 5 to 7 beds at the jail are full of essentially mental health patients waiting for state disposition, because there's just not enough places to put them. So, take-home point is, this guy fit all the elements of our protocol for cervical immobilization, and was ultimately cervically immobilized, and did have a cervical fracture. Whether the fact is it was going to, you know, it was going to cause him severe but he needed to be stabilized from the get-go. And just because, and the fact that he wasn't able to normally communicate because of his mental illness. He can't even give you a pain scale. Maybe you should have used the pediatric one with the smiley faces or sad faces. All right, different kind of a case. Breathing difficulty, 69-year-old female complains of shortness of breath. Says she's had a cold with multiple asthma attacks in the past 2 days. Episode began several hours ago. She used a Pro-Air MDI several times without relief. States increased MDI usage the past 2 days, denies chest pain or productive cough. Patient sitting in chair on O2 by a non-rebreather per fire. Appears short of breath, speaks in 2 to 3 word phases, anxious. Blood pressure is 228/84, pulse 92, pulse regular, respiratory rate 40. Upper right lung sounds diminished in the upper right, wheezing, rhonchi noted, left lung diminished, wheezing, rhonchi, etc. Wheezing, wheezing, wheezing. Meds Neb started on the scene. Oh, the other, I think, historical things about this patient is she was a known COPD patient. She continued to smoke 3 packs a day. Her husband was also sick. They've been concomitantly sick together over a period of a week or 2, and she ultimately turned out to be positive for influenza, as did he ultimately. Assisted a stair chair, patient anxiety increasing, got 125 solumedrol, started code 1 to legacy, second albuterol atrovent treatment, patient anxiety increases, she continually pulls off her O2 monitor, rips out her ETCO2 monitor, EKG leads, MedNeb, CPAP begun with good results along with her MedNeb. Then she pulls the CPAP off. So we go through the albuterol, et cetera, et cetera. Capnography is about 24, so she's hyperventilating. Pulse oximetry is 96. Pulse and heart and blood pressure stay up. More albuterol. Capnography is up to 35. Say, oh, this is good, right? No, no, no. Next time it's up to 48, then to 46. Pulse is still 110. Respiratory rate is 40, shallow, labored. So she got a little Versed for CPAP sedation. Was that the best drug, or it's in your list? She could have had ketamine. I think either one was okay, and this patient did relax to start with. Change in EKG and unable to maintain SpO2. Upgraded to code 3, diverted to Peace Health. Requested ALS assist. They got it. They stopped and got an ALS. So respiration assisted with BVM. RSI performed due to fatigue, falling SpO2. Request by patient to be intubated. Intubated 1 for 1 with a 7.0 with the King Vision. ET placement confirmed by ETCO2 and waveform. So we get scooting along here. She's intubated, ETCO2 waveform detector is good. Her capnography after intubation is 61. So she's now CO2 retaining significantly. Now her she's got some ST segment elevation noted in 2-3 AVF, V3 and V4, probably ischemia. CO2 value is 72, 75 on arrival at the hospital. ETCO2 waveform was done as she was transferred to the gurney. It was confirmed by the ED staff. So, respiratory failure in the presence of a already decompensated COPDer. So she had in-hospital diagnosed with COPD exacerbation plus pneumonia. She started out with the flu, went on to with influenza, and went on to a pneumonia. She had diabetes mellitus, hypertension, SIRS, and sepsis. She was extubated on 4/8, but re-intubated the same day because she had increased wheezes and laryngospasm. On 4/10, she appeared to have had a CVA. She didn't follow commands anymore. Ultimately died on hospital day 13 with a left hemispheric CVA, pneumonia, sepsis, etc. Her husband, in the meantime, was brought to the hospital a day later with severe COPD exacerbation, respiratory failure, intubated, and he just up and died. He was behind her a little bit because he smoked only 2 packs a day. So, okay, now this is a great, patient lying in grass in fetal position complains of nausea and vomiting due to heart problems. States her heart sometimes goes into AFib. She can feel it happen as she takes metoprolol when it does. Current episode started 2 hours ago, took her metoprolol and doesn't seem to be working. She has slight shortness of breath, chest discomfort, feels very weak and doesn't want to move. Yeah, I wouldn't want to move either. What's her heart rate? What's her heart rate? Pretty damn close. It's certainly above it's above 220. It's probably closer to 250, 260. That's pretty fast. And okay, so my basic rule. This is pretty nice and wide, right? Agree? I would call this wide. So, is this VTAC? My basic rule is on an adult, I can't see a VTAC occurring in with a rate of 220, 250. That's got to be supraventricular, a short reentry circuit. So, I mean, I suppose you could have VTAC. I certainly couldn't degenerate the VTAC. Now, we also have another hint, or another anxiety here. This person gave us a history of atrial fibrillation. When I see atrial fibrillation with a wide complex, I begin to worry about things like WPW syndrome. And basically, we don't treat. Now, I don't want to. If we were going to treat this person with drugs, I wouldn't want to treat this person with something that would block the AV node, because that will end up then with ventricular tach or ventricular fibrillation. So we would avoid adenosine, we would avoid diltiazem and verapamil. Now, the nice thing about this, she is conscious alert. She doesn't have a palpable radial pulse. Her skin is pink, but it's cool and dry. Hands and arms are cold. She's complaining of nausea and vomiting. She's obviously not wanting to get up. So the beauty about this one is we can say, damn it, this one's unstable. So, now they called it VTAC. Gave her some Versed. Cardioverted at 100 joules. Patient screams in pain and then converts to a sinus tach at 80. States she feels much better, placed on a non-rebreather. Chest discomfort and shortness of breath are gone. Transported, code 3 to Peace Health. Blood pressure is 92/49. SpO2 85, it does come up. She feels 99% better. It's at 1%, so hard to please. 111/57 on arrival, so she's getting better. There's her shock. Okay, now I hate to tell you this, but I don't say this is not normal sinus. Oh, I have to lie to find my P waves in this one, and this one also I have to lie to find P waves. So it's probably an underlying atrial fibrillation lurking in there. I'm looking at this. You look at a few of these things here. I'm not sure that these are delta wave upsweeps or not, but doesn't make any difference. This person probably needs to go to a electrophysiologist and figure out what's going on with her. If she's got WPW, if she's got AFib. She wouldn't want to repeat this too many times. Okay, just as a reminder, we still have this. This is for AMR primarily. We are still doing the sudden unexpected death study. All patients with pre-hospital cardiac arrest, even if you have ROSC, draw blood as soon as possible after an IV IO start. Label the tube, patient name, EMS number, date of service, hospital face sheet if you have one, put it in the baggie that comes in your kit, put it in the ambulance cooler until they can take care of it. Now, if you want to indulge me, and I'm sure you do, for a couple of minutes, I'm going to give you, and unfortunately, let's see if I can make this bigger. Yeah, okay. All right. This is unfortunately not on a PowerPoint. This is on a thing. But we are done with the amiodarone lidocaine placebo ALPS study. We published it. And there it is. New England Journal of Medicine, amiodarone lidocaine or placebo in out-of-hospital cardiac arrest. There's all the primary authors, and in the back of it has all the other persons in Clark County that participated, Cliff and Jay, etc. Oh, before I go, I have to announce this. Okay, we have two people who don't get to listen to this anymore for a while. Mike Hollingsworth and Scott Meeks. After what, 25 years? Oh, so they are retiring. So I do not know. I do not know how I let anybody get out of here before I left. Yeah. So this is what we had. 326,000. Well, this is the background. There's almost 350,000 out-of-hospital cardiac arrests per year. About 80,000 of those are caused by VFib or VTAC. The majority of VFib, VTAC episodes are not terminated by shock or they recur afterwards, shock refractory, which is what we studied. And of course, that's associated with worse survival. The best survival is the guy who has an arrest, is sparked once, and recovers. So our main aim was to look at the effectiveness of amiodarone versus placebo. Secondary aim was lidocaine versus placebo and lidocaine versus amiodarone. And this is only on survival to hospital discharge after out-of-hospital cardiac arrest initiated by a shock refractory VFib VTAC. So, as you guys all know, adult non-traumatic out-of-hospital cardiac arrest, persistent or recurring VFib VTAC, vascular access, they got a vasopressor, epinephrine, and then they got amiodarone, lidocaine, or the saline placebo. The primary outcome was survival to hospital discharge. Secondary outcome was survival with favorable neurologic status. It's called we evaluate patients using what's called a modified Rankin score. So if the Rankin score is high, above 3, then that's considered good neurologic. Essentially, that means the patient went home with minimal, went home to activities of normal living without major deficit. Not went to a sniff because they were neurologically impaired. We also look for drug or vascular access related adverse events, look for the number of shocks after the study drug, admission alive to the hospital. Those are not major endpoints, but secondary endpoints. There was what we call an intention to treat population. That means anybody for whom you opened the drug kit, you intended to treat them. Now, you didn't use it, perhaps, but that was intention to treat. And then per protocol, the analysis population were study-eligible patients, randomized. Initial cardiac arrest was for VFib, VTAC, and they received study drug during shock refractory VFib or VTAC. We thought that the ideal sample size, this was all these really, really smart people, which I have no idea how they figure this out, but a bunch of really smart people get in a room and say, we need to have this many patients in order to power this to make it statistically significant. That's what power means. It was powered to look at the primary outcome, which was amiodarone versus normal saline, placebo. And it was thought that you'd have to have, to be meaningful, you'd have to have at least 6% increase in survival to discharge, which meant you had to have at least 3,000 patients total, at least 1,000 in each group. Now, it turns out they underpowered it. Lidocaine versus, so then we had, the three groups, lidocaine versus placebo, lidocaine versus so lidocaine, amiodarone, and placebo group. So we went through all this stuff. You don't care about all this stuff. But we ended up with a by the time we got done, 2 years plus of the study, we ended up with 3,026 people. So we needed 1,000 in each group. We got, in the amiodarone group, got 974, lidocaine group 993, and placebo group 1,059. So it, evens out to slightly more than 3,000 patients. The ages, now this is put in as to show that actually the study itself was extremely well designed, whether or not they designed it for power or not, because the randomization was perfect. Literally, there's no difference in the age groups. Literally, there's no difference between between males versus females. Public location, so the access to public, to being seen, access to bystander CPR, et cetera, was even in all groups. Witnessed, bystander witnessed versus EMS witness versus the rest, all the same. Bystander CPR was exactly the same in the groups. Calls to scene arrival was the same, literally. CPR process measures were exactly the same. By the time we got done with it, literally everybody is doing the same compression rate, compression depth, CPR fraction in all three groups. Advanced airway is essentially the same too. So that's exactly, exactly the same. Now, here is the scary thing that we got to this stuff. And unfortunately, I can't break it out we can't break it out. No one has broken it out for Clark County. No one has broken it out for the Portland Metro Clark County area. EMS call to the first drug is averages 19 minutes. which seems a little long. They got there 5 or 6 minutes. So what's the big delay for a 14-minute delay before they get the first study drug? Well, you have to do 2 rounds, basically 2 rounds of CPR, which is 2 minutes, 2 minutes, 4. So we got roughly 6 plus 4 is 10. So you got 10 minutes. So you've got another 9 minutes to get that first drug in. Now, here's the interesting thing. Look at EMS shocks. This is shocks to conversion before ROSC occurs. In the amiodarone, an average of 5.7. In lidocaine group, an average of 5.3. The placebo group, 7.1. Now, conversion, okay, so, and you notice they had 3, everybody had about the same before the first dose. They had 3 shocks average before the first dose. But then after the first dose of the study drug, there's a big difference there. 2.7 shocks, 2.4 for lidocaine, and 4 shocks to convert for the placebo group. So apparently the drugs are having some effect at that level. So, admitting live to the hospital, amiodarone versus placebo, 4.7, 3.9. Lidocaine versus placebo, 47, 39. Amiodarone versus lidocaine, exactly the same. So 6% and 7%, which turns out to be not statistically significant. Well, we said, well, maybe it's the problem of the hospital. So we looked at, and literally everybody in all the groups had the same kind of care in the hospital, the best we can determine. They all had, the same number had targeted hypothermia, same number had cardiac cath, the same number had implantable ICD, etc. So, and then there are some adverse events we were following. They weren't significant, but in the amiodarone group, more people required pacing, as you would expect, actually. And there were seizures. There were a few more seizures in the lidocaine group, as you might expect, too. Lidocaine can induce seizures. Amiodarone can increase the need for cardiac pacing. Survival to discharge. Amiodarone versus placebo, no significant difference. Lidocaine versus placebo, no significant difference. And there's no differences between the two. Favorable neurologic survival, no difference in amiodarone versus placebo. No difference in lidocaine versus placebo. Now, this is the a little sub-study, and they didn't allow us to actually write this up as a result because it wasn't intended. We didn't write it down as our intention as an endpoint. We didn't say we'd look at this, and they said, well, maybe you didn't power for this one either. However, they liked it. They liked the information so well that the writing for the New England Journal is a real pain. They have editors who are the toughest nuts in the world. They just make you stick to exactly. Plus, you have to stick to exactly the number of words that they say you can have. I wanted to use emojis on some of the stuff, but they thought that wouldn't work. So they, but the 2 of the editors then wrote an editorial that follows right after our article in the New England Journal, and they talk about this part, because this is the important part. Witness versus unwitnessed cardiac arrest. So there were more bystander witness, almost 2,000, versus 900 or 850 or so unwitnessed arrests. Survival to hospital discharge of the witnessed versus unwitnessed. So bystander witnessed, amiodarone versus placebo, a significant difference, 5%. Lidocaine versus placebo, 5%. Significant difference, significant at a p of 0.03 and 0.04, which is a statistically significant thing. Unwitnessed arrest, there's no difference. So, here's our conclusions. These are the conclusions at the end of the study that we had to print. Overall, neither amiodarone nor lidocaine significantly increased survival to hospital discharge or favorable neurologic outcome. Both drugs, however, improve survival to hospital admission, improve survival to discharge in witnessed VFib, VTAC arrest, and adverse drug events were infrequent and probably not significant. So your way of saying that is that probably no harm with the drug. Now, the limitation of the study is late drug treatment, 19 minutes as an average. Hospital care, although it appears that they were about equally, the hospital care is really not very well standardized at this point, and we didn't have a way to develop. And it turns out that probably the study was underpowered. We probably needed about 3,000 patients in each group, 9,000 patients total, which would have taken us, what, 10 years?
Let's do it again.
Yeah. And of course, that's not going to happen because NIH has decided not to fund rock, essentially. So you've got the glass is half full, the glass is half empty kind of thing. So if you think there's no significant overall survival benefit, do you avoid the use of antiarrhythmics just because it costs money? Or shall we consider still using antiarrhythmic drugs because admission alive to the hospital, it increases. The trend is, there's a trend in overall survival to discharge, although there's not it wasn't significantly significant. There's an increased survival in witnessed cardiac arrest, and there's no evidence of severe harm. And then you translate it. If you have an increased survival of 3 to 5%, that's 1,800 people a year in the United States. So that's probably where our money is. So our takeaway from this is that we will continue to use, and the choice is, do you use amiodarone, do you use lidocaine? There's no significant downside to using either drug. There's no significant difference between the drugs. The cost has come down, and we use amiodarone for other things, much more than we do lidocaine nowadays. So we will continue to use, and at the scene, you probably don't know about, you probably don't have time to entirely grill the bystander or the person as to whether they actually witnessed the arrest or not. So we'd just do it in any VFib arrest, recurring VFib. The idea probably is to get the drug in sooner. There's some indication that giving, in the first 1 or 2 shocks, giving high dose epi, which is 1 milligram epi, may not be the correct thing. That may encourage continuation of VFib when the heart is still in the electrical phase. So there's a study going on right now, not in rock, but an independent looking at using half dose, 0.5 of epi, see if there's a difference. I don't know what to do with that yet. I do know one thing, though, that one of the other things that we didn't mention in this is that the route of administration made a big difference. Clearly, there was more cardiac. Clearly, there were more conversions and earlier conversions when the actual study drug was given by a peripheral IV rather than an IO. Now, that doesn't mean I don't want you to do IOs. It's just that I want you to consider you're doing, because sometimes you have to put an IO in just to get, because you can't find a vein. If CPR, your best CPR, the best pit crew CPR is 25% effective, putting out 25% of your cardiac output. That's the best you can do, hope for. If in a beating heart, it takes you 20 seconds to get from a tibial vein, to the heart, to the central circulation, at 25, it'll take you 80 seconds when you're doing CPR. So I think that's the take home from peripheral IV versus an IO. So I say my place of choice is to drill them in the shoulder, put it in the humeral head, where you've got 5 to 10 seconds between humeral head and central circulation. So you got to practice those humeral heads more. That's also the placement of choice in a trauma patient too. So, do you have any questions about that? I mean, really, some of the best things that this was, from an EMS standpoint, the actual implementation and running of this study was as good as anything that has occurred in any hospital study ever, because, I mean, you cannot get a better, it'll almost look like we lied on the even randomization of the patients. And then the fact that even the CPR was exactly the same. I mean, people learned very quickly over a period of several months to get that CPR down cold. And this is off of actual data. This is not what you remembered and wrote down. This is off the PCO files. So we know what the CPR is doing. We know what time on the chest is, all those things. So it's very good. So you guys did a great job. I'd like to be able to drill down and see what the West Coast, particularly Seattle and we, look like. And I'm not sure we can do it, but I'd like to. Yeah, they all live in Seattle. Yeah, well, as being part Norwegian, the difficulty, there's so many Norwegians up there, you can't tell if they're alive or dead. Okay. So next month is skill sessions again, and we'll see you in the middle of the summer. Thank you.